I'm Dr. Tim Kosinski, and today's topic is optimizing anterior aesthetics with the inclusive tooth replacement system. Implant treatment has changed so much over the years. In the past, it was acceptable to place the implant in the maximum amount of bone and then focus on restoring the implant once osseointegration had occurred. Although limitations were apparent, improvements in implant and prosthetic design enabled the fabrication of implant crowns that could be placed predictably, with confidence in the long-term success of the restoration. The creation of internal retention designs in the implant body, such as notches, Morse tapers, and internal hexes, further improved outcome. As restorative outcomes have become more predictable, expectations for implant cases have made a substantial shift towards aesthetics. So let's look at the figures. In Figure 1, the patient presented with a symptomatic and mobile maxillary right central incisor. The adjacent teeth were unrestored. In Figure 2, you can see that the radiograph illustrates a horizontal fracture in the maxillary right central incisor. Figure 3 demonstrates the clinical crown being removed using simple finger pressure. This revealed a compromised root structure. Note the inflammation of the surrounding tissue due to the movement of the horizontally fractured tooth. In Figures 4, we show the physics forceps being used to atraumatically remove the root structure, maintaining the facial plate of bone, and thus facilitating predictable immediate placement of a dental implant. In Figure 5, we show that the root anatomy was assessed to determine the appropriate length of the subsequent implant. The facial lingual and mesial distal dimensions of the root were evaluated so the tooth could be replaced using the inclusive tooth replacement system. In Figure 6, we show drills being used, which are included with the system, and these were used to prepare the extraction site for the dental implant. In Figure 7, we see that a 4.7 millimeter by 13 millimeter inclusive tapered implant from Glidewell Direct was threaded into the prepared socket site. In Figure 8, the digital radiograph of the implant shows the ideal position at the crest of the edentulous ridge. Figure 9 shows that because the implant was optimally placed at the crest of the ridge, a 3 millimeter tall healing abutment was initially placed into the implant and torqued to 25 Newton centimeters. A removable transitional appliance was immediately seated for aesthetics, as shown in Figure 10. Figure 11 shows that 2.5 weeks following implant placement, a traditional impression of the implant was made. Note that although the position of the implant was ideal, the tissue contours and interdental papilla had not yet been established because of the traditional round healing abutment was placed immediately following implant placement, so it collapsed. In Figures 12, we show a clean, crisp final impression with no voids or distortion that was made, along with an opposing impression and bite relation. Figure 13 illustrates that after pouring and scanning the master cast, CAD software was utilized to design the custom healing abutments. In Figure 14, we show custom healing components that were produced by the lab were seated on the master cast. The custom milled root contoured healing components would be essential in establishing an optimal emergence profile, aesthetic tissue contours, and interdental papilla for the final restoration. Figure 15 shows the custom healing abutment, custom impression coping, and custom temporary abutment that were milled with precision from titanium, while the Biotemp's transitional crown was fabricated from polymethyl methacrylate, or PMMA. All were provided to the doctor in order to maximize clinical options and idealize the aesthetics of the final implant retained crown. In Figure 16, after receiving the CAD/CAM produced components from the lab, the custom healing abutment was placed in order to train the soft tissue to mimic the original root shape of the tooth. The patient wore a partial removable appliance until the final impression appointment. In Figure 17, following 4 months of healing, the patient returned to the office for the final impression, exhibiting excellent tissue health surrounding the custom healing abutment. The custom healing abutment was removed, revealing anatomically correct contours that would facilitate an ideal emergence profile. The final implant impression, as seen in Figure 18, was made using the custom impression coping, which has the same patient-specific contours as the custom healing components. This allows the lab to accurately design the final crown while accounting for the final soft tissue anatomy. The custom temporary abutment, as seen in Figures 19, and Biotemp provisional crown were placed in order to further establish the emergence profile and interdental papilla, while the final custom abutment and crown were fabricated by the lab. The design for the definitive implant abutment was finalized based on the final impression, as seen in Figure 20. The morphology of the custom abutment mimics the root form of the tooth being replaced, fostering a natural emergence profile for the final restoration. The final implant retained crown was designed to mirror the shape of the natural left central incisor, as seen in Figures 21. The final soft tissue architecture of the implant site allows for the construction of an anatomically correct crown shape. The laboratory provided a seating jig, seen in Figure 22, to help position the final abutment in proper alignment, allowing for torquing of the abutment screw to 25 Newton centimeters without risk of affecting the implant. In Figures 23, I want you to note the natural emergence profile and ideal gingival margins of the final monolithic zirconia abutment, helping to eliminate any periodontal concerns of residual subgingival cement. The digital radiograph in Figure 24 illustrates ideal margins of the custom abutment and complete seating into the body of the implant. The final Bruxer crown was cemented into place, as shown in Figures 25. Note how the interdental papilla and soft tissue contours established by the custom healing components allow for the ideal crown margins. The patient was thrilled with the final implant results in the aesthetic zone.